the segue from there eventually is when a patient reaches a point where there's a diagnosis of 6-month life expectancy or less, then the hospice team comes in, and now you have this fourth concentric circle. So hopefully you can kind of picture this in your mind, these rings overlapping and care needs overlapping. But palliative care is that third concentric ring, and again, it has overlapped with the other folks and specialties. The elements of a good quality palliative care team involve integrated teamwork, management of pain and physical symptoms, the holistic care we talked about, having caring and compassionate, skilled providers. I recall long ago Dr. Mulder telling me, this medicine isn't rocket science. I can teach the medicine, but I can't teach compassion. You either have it or you don't. Some people are born with it. Some people have it forced upon them to events in life. But you need to be compassionate, and it also involves timely and responsive care. And again, going back to the education and the negotiation, it involves patient and family preparedness. And we as a team are very involved in that. That teamwork that we talk about, right? It starts with our receptionists and our MAs and our finance folks and our IT department and all the people the schedulers, all the people who are doing the important work in the background. And then it extends out into the nurse practitioners, the physicians, the nurses, and then grows out of there. If you think of it as a tree with roots and then a trunk and then the branches, then the teamwork begins to involve the specialists that we referred to before, those that were already involved in the case, as in say a lung patient with either a pulmonologist or an oncologist. But then it goes outside of that too, to working with interventional radiology and working with counselors and working with compounding pharmacies and the hospital pharmacies and pharmacists. All these members create this team that hopefully is performing this holistic care. Management of pain and physical symptoms, we touched on those a little bit ago. So whether it's physical pain, emotional pain, spiritual pain, or the physical symptoms, fatigue and weakness and depression and anxiety, we're here as a palliative team to address that. Within Trillium, within Holland Home, Trillium Palliative Services is our arm that is involved in this. And oversight starts with Mina as our CEO and our Vice President, Carolyn Pleetstra, and then Renee Wheaton and Tammy Sue Veldkamp, Dr. Mulder, and then myself. And then we, of course, as you know, many of you know, we have our staff too, and our supporting physicians and nurse practitioners. I'll go into these things in more detail, but we have our palliative services clinic at Raybrook. We work in the hospitals, at the cancer clinic at Metro, through the Trillium Institute and through Faith Hospice. And also, hopefully, we're integrating our care with Atrio and what they do. So our hospital-based services are at Metro Hospital, with some limited involvement at St. Mary's. At one time, we had a stronger presence at Blodgett and Butterworth. In the future, we hope to return there and beef that up again. But right now, predominantly, our work is at Metro. Dr. Mulder and Dr. Dupuy and our two new physicians, Dr. Kayla Andrus and Dr. Michael Dosman, carry a lot of that load. And we would be lost without Barb Opperwall, who is an amazing nurse practitioner and smarter than all of us put together. And then we also have Jill Powie, our nurse practitioner, and Dr. Sharp, Rouse, and Fitzgibbon as backup for those folks. So when they're at the hospitals, our palliative teams are coordinating with the emergency room staff, the ICU staff, and working with interventional radiology and the hospitalists, specialists, and social workers. So this goes back to talking about education and negotiation and teamwork. For this service to be successful, Dr. Dupuy, Dr. Andrus, Dr. Dozman, Barb Oberwall, you have to know how to work with a lot of different people in different specialties with different motivations and expectations, and do that equitably and diplomatically. You know, Dr. Mulder can speak to this a little later, but a lot of what we do in the hospital involves either goals of care discussions or symptom management. And in every hospital system, it can be a little bit different, and in every department, it can be a little different as to how that's weighted. At Metro, I feel that we have a free rein to engage in this sophisticated symptom management, and as well as in being involved in the goals of care discussions. In other systems, palliative staff may do more goal of care discussions and more basic medicine. But one of the things I think we all enjoy about what we do in this area, and a lot of this is thanks to Dr. Mulder paving the way, I think our staff is trusted to do the more sophisticated symptom management, you know, and that can involve, again, coordinating with interventional radiology and running pumps and infusions and supporting folks with the full armament of symptom management tools. Also involves a lot of family and staff education that I talked about before, and also assisting with transitions of care, whether the patient is transitioning out of the hospital and would need eventual clinical support through the palliative services clinic, or coordinating with their primary care physicians to carry forward whatever we have created with respect to a care plan. And in some cases, it involves coordinating the transition into hospice as well. We also have our clinic. It's at Raybrook on the ground floor, the Trillium Palliative Services Clinic. Barb works there, as well as Shannon Middlemiss. I think Hannah Rosma has a little bit of involvement there, and some others. It's referral based, so we treat folks there, and it involves, again, all aspects of symptom management and can augment both primary and specialist care. And going back to what we said before, they're involved in helping folks with physical, intellectual, emotional, and spiritual discomfort, and assisting with transitions of care. I like to think sometimes of palliative medicine as playing Captain Obvious in the entire healthcare machine, being the ones to help folks know where they're at with respect to their disease, what can be done to treat them and to steer them, whether that's towards options for controlling their pain and their symptoms, or again, referring to hospice, referring them in that direction. So if you haven't had a chance to see the clinic at Raybrook, it's beautiful, and we're very fortunate to have that available. And I would encourage you to go down and look around and see that. We also work out of the cancer clinic at Metro 2 days a week right now, hopefully more in the near future as we have more physicians on board. At one time, we had a pretty robust practice over at Spectrum too, and you know, the hope is that we are able to do that again someday. Right now, our hands are kind of full with Metro and the cancer clinic there. And you know, obviously, cancer patients, many of them deal with pain, and whether that's physical pain, emotional, intellectual, spiritual, what we call total pain, which involves all of these things. We're there to help out with that. So well as nausea and vomiting, and helping with delirium and anxiety, or dyspnea, breathing, fatigue, weight loss, goals of care. We're there to augment the oncologist and the oncology staff, and help people walk through their diagnosis and their treatment. And we're there to, again, play Captain Obvious and assist the oncologist in difficult conversations about what goals of care are, and ultimately for the patient. Some examples, and this is barely the tip of the iceberg, but some examples of referrals that we might receive. The first example, a COPD patient, emphysema patient, is admitted to the hospital with chronic and worsening disease with uncontrolled breathing problems and associated emotional, physiologic stress and socioeconomic stress. So we're there to, if the patient, referring back to those concentric circles, if it's chronic disease, but it hasn't really reached end stage yet, we're there to set them up with a medication plan and a therapy plan to try to help control those symptoms. You know, the pulmonologist is there to keep the disease itself at bay. We're there to augment that by helping control the symptoms associated with that. And often, if you can control the symptoms, you can decelerate the slide, the decompensation of the disease itself. So you know, that's one case where we're helping to augment what the pulmonologist is doing. Going back to what we said about goals of care, if this is the fourth hospitalization for this patient in 6 or 8 weeks with a COPD exacerbation, we're also there to have those goals of care discussion and say, you know, the pulmonologist has done everything they can, and the hospital's done everything they can, and you're bouncing in and out. You know, where are we at in your disease trajectory, and begin those soft discussions about hospice and what they really want, and is being in the hospital repeatedly for weeks at a time what they really desire. A second example would be a congestive heart failure patient, a CHF patient, who graduates from hospice. They've gone through a couple certification periods, and they're actually doing better. And we don't see that they need oxygen anymore, and they're not struggling to breathe at rest, or their dyspnea has improved. But they still can struggle with disease burden. This would be a good patient for us to refer out of the hospice program into the palliative program to help with disease burden and help them with fatigue and their breathing and any arthritic pain, anything like that associated with this. And also the readjustment to, gosh, I'm not on hospice now. What does this mean for me, and what does my life mean? And it also enables us to kind of keep an eye on those folks in the event that something changes and they need to go back on hospice. A third example would be a patient with pancreatic cancer. That patient's just been newly diagnosed, and they're trying to wrap their head around the diagnosis, but at the same time they're struggling with pain and with nausea. So the palliative team is there to set them up with a program, a medication regimen, and a treatment program to help treat that nausea and relieve that pain. But also to talk them through emotionally, intellectually, spiritually, what this diagnosis means, and to walk side by side with them as they again establish what their goals are, and where they want to be in a week or a month. And the last example would be a patient with chronic pain due to a past motor vehicle accident, and they continue to struggle. They've been referred to the pain clinic. They're a primary care physician, and they're orthopedist. They've outstripped their ability to try and help with this. Well, we are masters at helping people with pain like this, and understanding the different types of pain and the tools at our disposal and the referral sources available to try and help somebody like this. They're not a end-stage disease or chronic disease like a cardiac patient or pulmonology patient or even a cancer patient. It's a person in a totally different category, and we're here to serve them as well. So to recap, just kind of to let everybody, baseline everybody and let everybody in the organization knows what the palliative program does, and it's where it's at and where it serves. And again, it's we discussed what palliative care was. If you remember nothing else, remember it involves goals of care, and it can involve treating symptoms or whatever they may be in chronic disease. We work in the hospitals. We have the capacity to work in all the hospitals locally and have a history in them. Mainly, we're at Metro right now. We have the clinic at Raybrook on the ground floor. We also work at the clinic at Metro. We receive referrals from primary care doctors and from specialists. And we're very multidimensional and holistic with a broad base of folks that we can refer people out to for additional help. And hopefully we're integrated after this presentation in all of our minds with Faith Hospice Services, as well as with Atrio Home Health and with the Trillium Institute too. So that's a quick review of who we are and what we do. Are there any questions?
Sure. Thank you so much, Pat. You can go ahead and release your screen so we can see people now again. And those that are interested in asking questions, you'll need to simply manually unmute and ask away. I'm also monitoring the chat box, so if there's a question that someone might have that they would like to ask there, you may ask through there. I'm going to go ahead and stop the recording so that people can feel like their questions are just between us. So.